Alright, hi everyone. This is just going to be a quick review of the material for Exam 2. So this study guide is posted for you on Canvas. Exam 2 is going to cover the lectures on Assessment, Diagnosis, and Treatment, which was Chapter 4, and then Anxiety Disorders, Chapter 5, Disorders of Trauma and Stress, Chapter 6, and then part of Chapter 7, specifically the part of Chapter 7 about depression. So there will be no information about bipolar disorder on Exam 2. The specifics of bipolar disorder will be discussed and will be on the material for Exam 3. So briefly, we said that we always start with an assessment because it gives us information so that we can make sure our diagnosis is appropriate and make sure that we choose the best possible treatment. It also gives us information about whether or not our treatment is working, so we can refer back to maybe the level of symptoms a client had before treatment and see if we're getting some improvements throughout treatment. Now, in order for your assessment to be helpful, it needs to be high quality, which we talked about, for example, might include standardization. So the test needs to be administered, scored, really just treated in every way the same for every person taking the test. If we don't follow the instructions or if we don't score the way we should, then our results really don't tell us anything. We also talked about how tests need to be reliable and valid. Reliability refers to consistency in our results. Of course, reliability is important, but it is possible for us to be reliably wrong. So reliability is not enough. We also need validity. And validity refers to making sure that we are accurately assessing what we are supposed to be assessing. So we talked about different ways to gather assessment information. We talked about how interviews happen. It's a great way to build rapport with a client, probably the first thing you do. Now, based on your own personal preference and based on the preferences of your supervisors, there are different types of interviews. A structured interview would have a specific list of questions to be asked in a specific order, and oftentimes includes more closed-end questions. Things like, how many caffeinated beverages do you have a day? And how many hours of sleep do you get a night? Instead of asking more open-ended questions, things like, tell me about your substance use or tell me about your sleeping habits. With an unstructured interview, you have more open-ended questions, but you also can feel free to take it in any direction that you feel necessary. So if you feel like you need to follow up on certain issues and maybe spend the majority of your time talking about certain parts of the person's personality or life, you are free to do that. Now, of course, there is some middle ground here. You can have a semi-structured interview. Now, as I said, there are limitations with each. With structured, you get a lot of good information and make sure you didn't forget anything, but you might not have an opportunity to follow up on something that maybe should be followed up on. With an unstructured interview, though, you lack reliability. Different clinicians might give unstructured interviews and they might all end up gathering different information because they went off on different tangents there. Tests, there are many different tests that a psychologist has to choose from. The types of tests that you use probably are impacted by, obviously, what your supervisor wants you to do, what you've been trained on. A lot of it has to do with your theoretical orientation. And so when we talked about different types of personality testing, for example, we said that projective personality tests are used almost exclusively by a psychodynamic therapist, although a therapist with a different orientation might use these to gather a little bit of extra information. They certainly wouldn't be the primary way that you would test. Now, projective personality tests basically are presenting a person with something ambiguous and then asking them to do something with that. So with a Rorschach, you show them an ambiguous ink blot picture. With a thematic apperception test, the TAT, maybe we show a picture and ask you to tell a story about the picture. The idea is that because a psychodynamic therapist believes problems come from your unconscious conflicts, you couldn't directly answer a multiple choice question about how you feel right now. But if I show you a picture and you project your internal conflicts onto it, then I may be able to interpret that. On the other hand, Structured personality tests or personality inventories are much more straightforward, asking questions specifically. It's all self-report, asking a client to tell you, how do you feel? What kinds of things do you like to do? Multiple choice questions that are very obvious, not something ambiguous like a Rorschach ink blot, but a very straightforward question. Now, we talked about a couple examples of these. The MMPI and the PAI, both of these employ true-false questions. The difference is that the PAI also includes things like slightly true or mainly true, so that a person doesn't necessarily have to say true or false. Both of these measures are reliable, they're valid, they have good norm reference data, which basically means they've been standardized with large, diverse samples. Both of them measure many different areas of psychological problems, and a good thing about them both is that they both include some kind of preventative against a person just maybe lying or just not paying attention. So there are validity scales. The PAI has the advantage of having more validity scales and also more clinical scales. So there are things that the PAI measures that the MMPI does not. But they're both considered highly valid, highly reliable measures. We also talked a little bit about intelligence testing, about how this is something you might do if you're worried about how a client's doing maybe in school, if you're thinking maybe an intellectual disability or learning disability. But also it's just interesting sometimes to see how your clients approach a task. So an intelligence test like the Wechsler test is supposed to measure your potential to learn. Not measuring things you've already been taught, but measuring things that your ability to learn, basically. So things like perceptual reasoning, verbal comprehension, working memory, processing speed, that kind of thing. We also said that you might use observations, which is really helpful if you're able to do so. Naturalistic would be doing those observations in your client's natural habitat, at home or at school. Of course, you have to get permission to do that, and sometimes it's not feasible. So you can also kind of simulate as realistic an environment as possible in the lab or in your clinic and watch the client there. You can also have the client engage in self-monitoring where they make notes about whatever the issue is. So how often do you have thoughts about hurting yourself? How often do you drink alcohol? What time do you go to bed and what time do you wake up? That kind of thing. Of course, when you have a client who is coming to you with a problem, self-monitoring may be challenging for that client. It's really time consuming. It's a lot of time that the client has to put into it. But also the client may not be honest with you, or they may not be very vigilant about keeping accurate records. So sometimes that self-monitoring can be misleading to the clinician. And of course, when it comes to naturalistic observation, if someone knows that you're watching them, they will probably change the way they behave. We also talked briefly about issues related to diagnosis. We said that misdiagnosis is always a concern, and that's why we try to gather as much information as possible during the assessment phase. We talked about how there are some clinicians who have concerns over a self-fulfilling prophecy. Basically, if you believe something is true, sometimes you behave in ways that make it true. So giving a client a label could potentially make problems worse. However, we also mentioned that it's sometimes necessary to diagnose for insurance to pay for the sessions, as well as for the client to, feel confident that you are identifying the problem, and you need to know what the problem is so you can do research on how to solve it, at least to the best of our ability. Now, our diagnosis is based off of our manual, the DSM, which is on the 5th version. So we talked about how almost half of the people in our population have met criteria for diagnosis at some point during their lifetime. You can take a look at those numbers, but it's pretty common. We talked about how the DSM-5 includes both a category and a dimension, so not just the label of the specific diagnosis, but also information about how severe the problem is. We talked about how reliability and validity is important for a classification system, and also how the DSM-5 seems to be more reliable and valid than previous versions. but probably still has some work to do. We touched on some changes from the DSM-4, which this is what this stands for. So it's the DSM. IV is Roman numeral for 4, and the TR is text revision. So this is the DSM-4 text revision. This was the version we had before the DSM-5. So we talked about how, for example, autism spectrum disorder is now an umbrella term that includes what used to be considered autistic disorder as well as Asperger's syndrome. We talked about how OCD is being conceptualized differently, about how PTSD is being conceptualized differently, that kind of thing. We said that therapy is typically helpful. However, there was also that warning that it could be potentially harmful if we misdiagnose a treatment or misdiagnose a client or choose a treatment that is not a good match for a particular client. We could cause that client to maybe give up on therapy, and then maybe symptoms get worse after that. All right, Chapter 5 talked about several different issues related to anxiety disorders. We said that fear and anxiety have the same symptoms, basically. The difference is that fear is a short-term response to an actual threat, whereas anxiety often feels like it's long and drawn out and not necessarily in response to something that is particularly threatening. So, anxiety disorders are some of the most common disorders that we see. We talked about generalized anxiety disorder as being a person who has anxiety related to several different areas of their life. We talked about how this could potentially be caused by, or at least we have some correlational data to suggest that there's correlations between things like poverty, or maybe being in a dangerous area, maybe being exposed to a natural disaster, that kind of thing, that can increase symptoms of generalized anxiety disorder. Specifically, when we talked about a couple of the theories of generalized anxiety disorder, we hit really on all of them, but some of the ones that have the most research support. So cognitive theory, as you would imagine, addresses the way that this person thinks. And so assuming that there are some thought processes, some attributions here that are not accurate or not helpful, then the therapy, the goal here would be to replace those with more logical, more realistic, more functional thought processes. And so the therapist would do that by kind of hypothesis testing with the client. You have this belief, now let's go look for evidence for it. Let's see if that's true or not true, trying to replace those dysfunctional thoughts with more functional thoughts. We also talked a little bit about the biological theory. When you hold a biological theory, you believe that there is a medical cause, so something like, for example, neurotransmitters. And so when you're talking about someone having anxiety disorder, then oftentimes things like SSRIs are prescribed, medications that work on serotonin, so those would be things like Zoloft and Paxil and Prozac. But there are other medications that might be prescribed that work on norepinephrine, and maybe even potentially dopamine as well. We talked about phobias, about how everyone has fears, but the difference is that a phobia is an extreme fear that causes dysfunction. So it's not realistic. The person is more afraid than they need to be of the particular item or situation, and it causes them some kind of dysfunction in their life. Now, this could be of things like, for example, a certain kind of animal, so maybe a dog, or maybe spiders, or maybe it could also be certain maybe weather-related situations, could be health-related situations, things like needles or blood. Now, phobias, as far as where we believe they come from, the research has most support for behavioral theory here. This is the idea that you're classically conditioned to have a phobia. So if you have a bad experience and you kind of generalize that to other situations, you develop a phobia. So if you're bitten by a dog, it's natural. Being bitten by a dog causing you anxiety, that's normal. The problem is that you learn the association between being attacked and all dogs. And then in the future, you might start to feel anxiety. Even if you look at a picture of a dog or see a movie that has a dog in it, it can create problems. So the therapies that we have based on this behavioral viewpoint are very effective, but they're not super pleasant for the individual going through them. So the idea is that once you become conditioned to be afraid of something, it's also likely to be reinforced if you avoid the thing you're afraid of. So if you're afraid of dogs and you manage to avoid a dog, that will help your anxiety go down. You'll feel better. Anything that makes you feel better is reinforcing. And so the next time you see a dog, you'll avoid that dog again. The idea behind the therapy, though, is that you have to face the thing you're afraid of in order for you to stop being afraid of it. For a couple of reasons. One, because your body cannot maintain that panicked, freaking out feeling for very long, so your body will calm down. But also because oftentimes we have this picture in our mind of something terrible that's going to happen, and if you can come face to face with the feared object and not have a terrible outcome, that can also reduce your symptoms as well. So we could do this all at once with flooding, where you force the person directly into the scariest version, or we can do a kinder, gentler, systematic desensitization where we gradually expose you to things that scare you and teach you how to relax and calm down and do deep breathing. So you have to choose the treatment that is really best for your client. We did talk about how biological preparedness could be an issue related to phobias, that perhaps as a species we are prepared to become afraid of certain things because they genuinely could potentially harm us. So things like snakes or spiders could potentially cause major illness or death. Even being afraid of the dark could have some biological support there. There's some sense in that especially if you're sleeping out in the open, something scary could sneak up on you in the dark. So maybe we are biologically prepared to acquire certain phobias more than others. We talked about agoraphobia, about how this is a specific phobia, or I should say, rather, it's a more of a generalized phobia, but it falls under the category of phobia, rather. With this phobia, basically the person does not want to be in places that are hard to escape. And so sometimes we see an overlap between agoraphobia and panic disorder, where a person who has a history of panic attacks might be afraid of having a panic attack in front of other people, or might be afraid of certain locations where they have previously had panic attacks. And so they start to avoid those places altogether. And eventually the end result can be a person who does not want to leave his or her home. So we know that agoraphobia does overlap with panic disorder often, but it is possible for a person to receive a diagnosis of agoraphobia without actually having panic disorder, although oftentimes they go together. Social anxiety disorder is another issue that's related to phobias. A person might be afraid of certain behaviors in front of other people, things like eating or public speaking, but it could also be just generally being around other people that causes this person anxiety. So there's a lot of research here to suggest that there's cognitive issues. People have beliefs about themselves that are not really consistent with good social skills. So they believe that they cannot be successful in social situations. They think people are judging them more harshly than they truly are. They think other people expect them to be perfect. So if your client has some thought processes that are not logical, then you're going to have to try to help them replace those with more functional, logical thoughts. And that's the cognitive part of the cognitive behavioral therapy. The behavioral part would be the exposure therapy, just like we talked about with other phobias. If a person is afraid of spiders, you have to bring them in contact with a spider in order for them to get over that. If a person is afraid of social situations, then you have to put them in social situations to help them get over that. So have a cognitive component combined with a behavioral component, and make sure that you are teaching your client appropriate social skills so that when they are put in social situations, things go well. Okay? Panic disorder would be a person who has a pattern of panic attacks. Now, a lot of people have a panic attack at some point during their lives. Maybe you have 2 or 3 throughout your lifespan. That's not panic disorder. Panic disorder happens when a person has a pattern of panic attacks that are causing dysfunction in their life over a significant time period. Now, these panic attacks often feel like a medical issue. So people may end up going to the emergency room thinking that they're having a heart attack, thinking that they're dying, and then get a diagnosis of a panic attack or panic disorder. Now, when it comes to panic disorder, there are a couple of options that we could think about here. First of all, a biological theory would suggest that maybe there's something wrong with brain anatomy and with neurotransmitters, and that this would need to be treated with medications. The kinds of medications we would often give here would be things like maybe SSRIs, but also benzodiazepines, medications that, while they are effective at calming people down who have anxiety, the benzodiazepines could be addictive and also can have some nasty side effects, can make a person very tired, not safe to drive typically while you're under the influence of benzodiazepines, and can be dangerous if you mix them with other medications of a similar class or if you mix them with things like alcohol. On the other hand, you could take a cognitive approach and you could say a person has a panic attack because they misunderstand their own body. They start having symptoms like their heart's racing and they start panicking about that and they start to wonder, is something wrong with me? And then their heart starts racing even faster. Instead, we want to teach people that everyone experiences those sensations at some points and that it's not necessarily a problem. So try to educate them about what panic attacks truly are and how they're not dangerous to a person's health. But in addition to that cognitive aspect, you may also include the behavioral aspect of exposure. So interoreceptive exposure is the term we use for when we expose a person to physical sensations that are similar to a panic attack. And while that may sound cruel and unusual, as all types of exposure do sound cruel and unusual, it helps a person be prepared. If you do this with the clinician there, the clinician is helping them practice their maybe deep breathing or their muscle relaxation. That way they're able to handle that situation, not be afraid of it when it happens outside of the psychologist's office. And then obsessive compulsive disorder, which has been classified in the DSM-5 as based more on its compulsions and less on its obsessions. So it's seen more as an impulse control disorder rather than an anxiety disorder. The obsession is an anxiety-producing thought or idea that a person feels like comes from outside of them and makes a person very anxious. And so the compulsion is then the behavior, whether that be physical or psychological, mental, that a person feels compelled to do in order to reduce the anxiety from the obsession. So if a person has an obsession about, I'm going to get sick, then the compulsion could be washing their hands, for example. Now, the relationship between these is that the obsession typically comes first. The compulsion then helps reduce the anxiety from the obsession. So the compulsion is then reinforcing. And what this means is the next time the obsession starts, the compulsion will probably follow. And so it kind of creates a vicious cycle here. Now, the behavioral therapy here, as I hope you're getting the trend, is exposure therapy, exposure and response prevention, basically exposing the person to something that triggers their obsession and then don't allow them to do the compulsion. And as I said, exposure therapy sounds cruel. Let me assure you that leaving a person with an untreated anxiety disorder is also very cruel. But with this particular treatment, when you remove the compulsion, although that makes the person very uncomfortable at first, it actually is helpful in the long run. The compulsion being so reinforcing is actually causing the obsession to stay around. So typically we do see a reduction in symptoms here. There's also the cognitive theory, the idea that maybe we're not understanding the obsessions. Everybody has thoughts that come out of nowhere and you think, where did that come from? Everyone has ideas that are disturbing to them. So perhaps the problem is that the typical person kind of lets those go, kind of gets over those. And a person who has OCD can't let it go, can't stop obsessing over this thought. So helping them realize that there's not anything wrong with them having the thought pop up every once in a while, but helping them see that they're indulging it and allowing it to continue with the compulsions is actually making the problem a lot worse. All right, biological theory, obsessive compulsive disorder can be treated well with certain medications, especially SSRIs. Of course, the concern is that OCD is a severe disorder that does cause a high level of dysfunction in many individuals. And if a person does the medication without the therapy, and then if a person stops taking the medication, or if the medication stops working, the person's symptoms can come back. So we have to always be keeping an eye on that. And we talked about classifying it differently in DSM-5. All right, briefly, Chapter 6 was talking about disorders of stress and trauma. So we said that stress is made up both of the stressful event as well as your response to the stress. And so everyone is placed under stressful events at some points in time. Your response will dictate your experience of that stress. We talked about how our autonomic nervous system is made up of your sympathetic and parasympathetic nervous systems, and that the sympathetic nervous system is overactive in people who have stress disorders. So when your fight or flight system kicks in, your muscles are preparing to run away. So your blood is being diverted to your limbs so that you can fight or run away. And so it's going to be diverted away from your digestive system, so digestion can slow down or stop. Your pupils are going to dilate to let light in so that you can see better. All of these things are just your body's way of preparing for a dangerous event. The problem is that a person who has a stress disorder, their autonomic nervous system might not be working in their favor. So the sympathetic nervous system could be overactive, where their blood pressure is always high, their pulse is always high, their respiration is always fast. And then the parasympathetic resting and digesting system doesn't kick in often enough. So the person feels like they are always in this emergency mode as far as their body is concerned. Now, when we talked about acute stress disorder and post-traumatic stress disorder, they basically have the same symptoms. Things like flashbacks and disturbing dreams related to the event, hypervigilance, that increased physiological arousal, all those symptoms we talked about. The difference is the timing. So acute stress disorder always begins within a short amount of time of the event and lasts for less than a month, I believe, or around a month. If it starts lasting longer than that, or if you didn't have any symptoms initially and then they come up at a later point in time, then you would be classified as having post-traumatic stress disorder. So it would have the same symptoms but different timing. Now, when we're talking about these disorders, as I said, there are some common themes of the symptoms, but the symptoms may also be different from person to person, and they may be different depending on the type of stressor that the person was put under. Now, we talked about several different risk factors for developing stress disorders. Really, anytime you or someone you care about is put in a life-threatening situation, a stress disorder is possible. However, the closer the stress is to you, if it happened to you, that's when you're most likely to develop the symptoms, or someone you're very close to, or if it was someone that happened right in front of you, that kind of thing is also an increased risk factor for developing a stress disorder. Also, having a pre-existing anxiety disorder can be a problem, as well as having maybe a negative worldview that may or may not be associated with depression. But then there are also protective factors. People who have social support, people who have good psychological health before a traumatic event happens are less likely to develop a stress disorder. Now, ways to treat stress disorders, there are several, but the one that seems to have the most research support is exposure therapy with cognitive restructuring. So the exposure therapy is having the person go back and talk about and revisit the stress or the trauma. Now, of course, that's difficult, but the idea is that if a person is avoiding thinking about it, it's always in the back of their mind, and they're afraid, if I do accidentally come face to face with some reminder of this trauma, I won't be able to handle it. So having them go through exposure therapy shows them that they can handle it. The cognitive restructuring bit, though, has to do with the fact that many survivors of trauma have some unrealistic or just not helpful thought processes about the event. So maybe they feel like they should have been able to prevent it, or it was their fault, that kind of thing. So when you first have a person tell you their story at the beginning of treatment, they might include some of those thought processes in there that are not helpful and that are making it harder for them to recover. What you want to do is to gently help them see that those things are not accurate and not helpful, and then by the end of therapy, when they tell their story to you again, you have the same basic story, the trauma that happened, which never should have happened. They never should have had to go through, but it did happen. But you want them to have a different perspective on it at the end, that it wasn't their fault, that there are things they can do to feel safe again, that kind of thing. And then our last lecture for exam 2 talks about mood disorders. We're talking specifically about unipolar depression here. With unipolar depression, we're saying that we do not have bipolar disorder, so we don't have manic episodes. So you would have to have a major depressive episode without the presence of mania to be diagnosed with a major depressive disorder. Now, these symptoms can fall into several different categories, but you have to have an emotional symptom, whether that be depressed mood or loss of pleasure or both. Remember that the term for loss of pleasure is anhedonia. But then also you might have motivational symptoms, you might have physical symptoms, you might have symptoms related to social functioning. There are many other different types of symptoms that can come along with that. Now, if you have an individual who has periods of depression, maybe interspersed with periods of regular mood, but the periods of depression are more severe, you would call that major depressive disorder. On the other hand, a person might have dysthymic disorder. Now, dysthymia or dysthymic disorder happens when a person is chronically depressed over a long period of time, but they experience those symptoms in a more mild way. And yes, it is possible to have them both at the same time, and then you'd be diagnosed with double depression, or the term we use is double depression. You would get a diagnosis of major depressive disorder and dysthymic disorder, but the term we use there is double depression. We talked about how depression can be caused by your environment, so it can be exogenous, but it can also be caused by biological issues, which would be endogenous. So the biological theory primarily focuses on serotonin. The individual doesn't have enough serotonin, or maybe perhaps norepinephrine or dopamine, so we would give medication to try to increase those neurotransmitters. The behavioral theory is that an individual's reinforcements and punishments have gotten out of whack. So you've been having too many punishments, not enough reinforcement. So then the person might stop trying to do things that they used to enjoy because they're not enjoying them anymore for whatever reason. So the therapy then, which we call behavioral activation, would just be to help a person set up a schedule of things that either A, they enjoy doing, or B, they feel good about themselves for doing. So maybe volunteering or cleaning out your garage, set a goal for yourself and meet that goal. And then the idea is that the more this person is reinforced, the less severe the symptoms will be. Cognitive theory has a lot of support when it comes to depression. The idea that people who are depressed have thoughts about themselves and about the future and about other people that are very negative. So we talked about just a few examples about perhaps they have learned helplessness, where because they've had bad situations they couldn't control, they stopped trying to control their situation at all. Or we may have people who have attributions that are not helpful. So an attribution is your understanding of the cause of something. So a person who is depressed might see everything negative that happens as being their fault. So internal, kind of stable, it will always be this way, it will always be bad, kind of global, everything in my world is falling apart. So we can try to help people recognize those attributions and change those attributions. And then also, the sociocultural view suggests that perhaps there are things in our environment. So we talked about how mood disorders are linked with relationship satisfaction. So being in a satisfying relationship, most of the research focuses on married couples, tends to be protective, whereas people who are separated or divorced are particularly at risk for depression. We also talked about issues related to gender. So we talked about how women are much more likely to be diagnosed with depression, and how this could be a situation where men express their depression differently, and so they're not diagnosed with depression, or we just misdiagnose men. Or it could be that women truly do have higher levels of depression because of things like hormone fluctuations, maybe discrimination in the workplace, or excessive stress related to family responsibilities, that kind of thing. So this has just been a quick overview of the material for Exam 2. Please let me know if you have any questions after you watch this video, and then be looking for our next lecture video after exam 2 closes. So I'll talk to you guys then.